Welcome to the learning session on asthma. Asthma can be simply put as hyperresponsiveness of the airway to an allergy. It is one of the most common chronic diseases globally and currently affects approximately 300 million people worldwide. The common clinical presentation is episodic breathlessness with wheezing and spasmodic cough. By the end of this lesson, you will be able to explain the risk factors of asthma, understand the clinical presentation of asthma, describe the diagnosis and management of asthma. Introduction. According to Global Initiative for Asthma, GINA, asthma is defined as a heterogeneous disease, usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. Proper understanding of the presentation of asthma and its etiopathogenesis aids in early diagnosis and proper management of asthma. Epidemiology. The prevalence of asthma has increased in affluent countries over the last 30 years, but now it has been stabilized with approximately 10 to 12% of adults and 15% of children affected by the disease. Most of these patients are atopic, presenting with allergic sensitization to a house dust mite, dermatophagoides teresinus, and other environmental allergens, such as animal fur and pollens. In developing countries, there is a rising prevalence, which is associated with increased urbanization. Asthma can occur at any age, with a peak age of 3 years. In childhood, twice as many males as females are asthmatic, but by adulthood, the gender ratio is equalized. Risk factors. Asthma is a heterogeneous disease having interplay between genetic and environmental factors. The endogenous risk factors of asthma are genetic predisposition, atopy, airway hyperresponsiveness, gender, ethnicity, obesity, and early viral infection. The environmental risk factors are indoor allergens, outdoor allergens, occupational sensitizers, passive smoking, respiratory infections, diet, and acetaminophen, paracetamol. Asthma is a heterogeneous disease having interplay between genetic and environmental factors. Several predisposing risk factors have been identified. Atopy is a major risk factor for asthma, and non-atopic individuals have a very low risk of developing asthma. Asthmatic patients commonly suffer from other atopic diseases, particularly allergic rhinitis, which may be found in over 80% of asthmatic patients, and atopic dermatitis, eczema. Atopy may be found in 40 to 50% of the population in affluent countries, with only a proportion of atopic individuals becoming asthmatic. Atopy is due to the genetically determined production of specific IgE antibodies, with many patients showing a family history of allergic diseases. This observation suggests that some other environmental or genetic factors predispose to the development of asthma in atopic individuals. The allergens which lead to sensitization are mostly proteins with protease activity, and the most common allergens are derived from cat, house dust mites, dog fur, and cockroaches in inner cities, grass and tree pollens, and rodents, and laboratory workers. Trigger factors. The various trigger factors for asthma are allergens, upper respiratory tract viral infections, exercise and hyperventilation, cold air, sulfur dioxide and irritant gases, drugs such as beta blockers and aspirin, stress, irritants such as household sprays, paint fumes, foods such as nuts, eggs, wheat, dairy products, shrimp, shellfish. Asthma may be manifested by various triggers and present accordingly. Occupational asthma is triggered by various agents at the workplace, and it may occur weeks to years after the initial exposure and sensitization. During the menstrual cycle, women may experience catamenial asthma at predictable times. Exercise-induced bronchoconstriction begins while doing exercise or within 3 minutes after it ends, peaks within 10 to 15 minutes, and resolves by 60 minutes. This phenomenon is thought to be due to a consequence of the airway's attempts to warm and humidify and increase the volume of expired air during exercise. Cardiac asthma is wheezing precipitated by decompensated heart failure. Cough variant asthma has cough instead of wheezing as the predominant symptom of bronchial hyperreactivity. Pathophysiology. Asthma is a chronic disorder characterized by variable airway obstruction, airway hyperresponsiveness, and airway inflammation. No histopathologic feature in pathognomonic but common findings include airway inflammatory cell infiltration with eosinophils, neutrophils, and lymphocytes, especially T cells. Goblet cell hyperplasia, sometimes plugging of small airways with mucus, collagen deposition beneath the basement membrane, hypertrophy of bronchial smooth muscle, airway edema, mast cell activation, and denudation of airway epithelium. IgE plays an important role in the pathogenesis of allergic asthma. IL-5 is important in promoting eosinophilic inflammation. Asthma may present with airway limitation and is caused by various factors: bronchoconstriction, airway edema, airway hyperresponsiveness, and airway remodeling. The inflammatory cells commonly involved in asthma are lymphocytes, mast cells, eosinophils, neutrophils, dendritic cells, and macrophages. The inflammatory mediators are chemokines, cytokines, and immunoglobulin E. Clinical presentation. Prodromal symptoms of asthma may precede an attack, with itching under the chin, discomfort between the scapulae, or inexplicable ear, impending doom. Typical physical signs are inspiratory, and to a greater extent expiratory, raunchy throughout the chest, and there may be hyperinflation. Some patients, especially children, may present with a predominant non-productive cough, which is cough variant asthma. There may be no abnormal physical findings when asthma is under control. The characteristic presentation of asthma is dyspnea, wheezing dyspnea, and coughing, which is variable, both spontaneously and with therapy. In acute severe cases, asthma presents with features such as gasping for breath, single breath counting, SBC, less than 20, cyanosis, altered consciousness, pulsus paradoxus, silent chest, severe retraction with nasal flaring, and hunching forward. Clinical variants. Based on the clinical presentation, asthma is of intermittent or mild, moderate, and persistent variants. GINA doesn't distinguish mild or intermittent variants, as the historical distinction is still unclear. In mild or intermittent variant, the symptoms are mild, presenting 2 days in a week or 2 nights in a month. The symptoms include coughing, wheezing, and inflamed airways, and may include exercise-induced asthma. The moderate variant may also present with mild symptoms, but with an increased frequency. Patients with a family history of asthma, increased exposure to allergens or pollutants, obese individuals may present with this variant. The persistent variant may present with severe symptoms appearing several times a day. This type doesn't respond well to regular medications and may need an aggressive treatment approach. The current session ends here. In the next session, we will discuss diagnosis, laboratory findings, and management.